when patients don't improve. Every experienced clinician knows that there are those patients who simply don't respond to our usual management approaches. The next step is difficult to take given it is often a referral for a surgical consideration. There are options, but what is the evidence that this intermediate approach doesn't simply prolong the inevitable? Two new studies begin to answer that question with some promising results. Each reviews an option that not only provides an alternative to surgery, but also allows for one more opportunity for manual therapy to be applied. Although small studies, the inclusion criteria and results strengthen the conclusions and set the stage for hopefully future, larger studies. The title of the first publication is Outcomes for Chronic Neck and Low Back Pain Patients After Manipulation Under Anesthesia, a prospective cohort study published in JMPT in 2014. The purpose of this study was to determine clinical outcomes for patients with either chronic neck pain or chronic low back pain after a single MUA treatment, manipulation under anesthesia. All subjects were previously managed with a series of manipulation treatments, but failed to demonstrate acceptable improvement. Although MUA is still somewhat controversial, recent studies and recently published guidelines are suggesting that this is a viable option for those patients who fail or cannot tolerate standard manipulation. The researchers described the MUA procedure as having three stages. First, sedation. The level of sedation in Switzerland, where this study was performed, is not as high as in other countries. Propofol is typically used due to its quick metabolism and quick return to consciousness by the patient. Secondly, pre-stretch was involved, which included passive stretching of myofascial tissues of the neck and low back in all planes. These were held for about 5 seconds, and then axial traction was applied. This was followed by spinal manipulative therapy, which consisted of high-velocity, low-amplitude thrusts in the main areas of the spine that were restricted. This was performed by a certified MUA chiropractor who was assisted by an anesthesiologist and someone to assist with stabilizing the patient. And finally, in the third stage, the patient is taken to recovery until conscious and cleared to leave. Patients were from a single chiropractic office in Zurich, Switzerland. Due to their failure to either improve or not reach an acceptable level of improvement, they met the main inclusion criteria and were sent for MUA. There were in total 30 patients, with 17 having chronic low back pain and 13 with chronic neck pain. Outcome measures included a numerical rating scale for pain and the Bournemouth questionnaire for disability. However, the Patient Global Impression of Change, which is a 7-point verbal scale, was used to determine improvement. Only patients with scores of 1 or 2 were considered improved in this study. At 2 weeks post-MUA, 52% reported clinically relevant improvement, with 45.5% improved at 4 weeks. Although there were statistically significant improvements for the numerical rating scale for pain and a Bournemouth questionnaire, improvement was largely determined by the Patient Global Impression of Change response. Again, only responses of better or much better were tabulated as improvement for this study. There were no differences in outcomes between patients with low back pain or neck pain, and there were no differences in outcomes between the sexes for the Bournemouth questionnaire or the rating scale for pain. More importantly, there is an odd outcome in this study. The baseline rating scales for pain were not severe. In fact, they were moderate at around 4 with a standard deviation of around 2. Bournemouth scores were similar. Post-treatment revealed little change in both the rating scale for pain and Bournemouth scores, with the NRS improving to a mean of about 3.18 with a standard deviation of 2.5, and a Bournemouth baseline score of around 24 improving to around 19.5 with a standard deviation of almost 14 points. It is surprising then and unusual when compared to other studies that patients rated their global improvements so high. Well, the good news is about half believed they were better or much better, even though the mean scores for the other outcome measures were not impressive. The researchers comment that when there is a statistically significant difference in a small sample size, such as this, it often translates into clinically relevant change. So to summarize, this is a great step in the direction of a larger study. It certainly suggests that patients benefit from MUA if they meet the study's criteria of a failure to respond to standard manipulation. Let's now move to another study on alternatives. The title of the second publication is Transforaminal Epidural Steroid Injections, followed by Mechanical Diagnosis and Therapy to Prevent Surgery for Lumbar Disc Herniation. This is published in Pain Medicine in 2014. The question the researchers attempt to answer is, do patients with non-centralizing pain change to a centralizing pattern after treatment with transforaminal epidural steroid injections? As a reminder, the purpose of mechanical diagnosis and therapy, aka McKenzie technique, aka directional preference, is to determine if a low back pain patient with radiation down a leg is influenced by positioning. The assumed preference is to cause the pain to radiate less or not at all and centralize to the low back. Here's a quick summary of the mechanical diagnosis and therapy approach to evaluation. It involves both prolonged positioning and repeated positioning in an effort to centralize pain and therefore discover a directional preference for treatment. If patients with non-centralizing pain and radiculopathy do not centralize, it may be that there is an underlying source that involves inflammation of a nerve root and is unlikely to respond to mechanical interventions. If the inflammatory aspect would be decreased by an epidural injection, then the pattern may change to a centralized one and may be more amenable to mechanical intervention. Inclusion criteria for this study required that there was extremity pain with or without low back pain, and that the lower limb to axial pain ratio clearly favored radicular pain, with the leg pain being greater than 50%. A lumbar disc herniation needed to be confirmed by MRI, and there needed to be on clinical exam 2 or more positive neurological signs. Exclusion criteria included centralizing at the initial MDT assessment, pregnancy, any contraindication for the use of corticosteroids or fluoroscopy, or suspicion of malignancy, fractures, spinal stenosis, or severe cases of spondylolisthesis. Outcome measures included the current measure of leg pain measured by visual analog scale, back pain-related disability measured by the Roland-Morris Disability Questionnaire, and again the global perceived effect with this 7-point scale. Secondary measures included back pain, anxiety, depression, medication use, work status, and other treatments during the follow-up period. Injection criteria were that if pain relief was between 50% and 80% on the visual analog scale, or if the patient refused, no further injection was given. Doctors could give up to a maximum of 4 injections. About 65% of participants received 2 injections, and no MDT treatment was given before injections. After injection, subjects were categorized into 4 response groups. Number 1, resolved symptoms. This was a total of 11 patients where there was no or irrelevant pain. These patients were given advice using the MDT principles. Number 2, centralizing and significantly less pain. This equaled 32 patients, and these patients were treated according to the MDT principles with direction-specific exercise and posture correction. Number 3 was non-centralizing and significantly less pain, which equaled 11 patients in this study. These patients were treated with information using the MDT principles and given advice to stay active and avoid any activities that would exacerbate the leg pain. And then finally, non-centralizing with high levels of pain and/or disability after injection. This equaled 15 patients, all who went to surgery. Success was defined as the patient not being operated on during the follow-up period of 12 months, and both leg pain and disability improving to at least 50% compared to baseline. None of the 54 patients, which equaled 78.3% of the total participants, with the partially or completely resolved symptom profile, had surgery during the following 12 months. Work restrictions and sick leave for the 54 patients decreased from 40% at baseline to 15% at short-term and 10% at long-term, seen in the front part of this graph. In the back part of the graph, we can see that the use of pain medication decreased from 54% at baseline to 11% at short term and to 6% at long term. The 15 patients who had high levels of pain and/or disability after injection all had surgery. These two recent studies are small, but they're timely in that given what appears to be a trend toward accountable care organizations and their subset of patient-centered homes, care for an individual requires the innovative approaches demonstrated here. A team of practitioners can work together, and with a focus on each other's expertise and an algorithm for a sequential approach, they can provide more efficacious management of patients.